Next up, we have a case presentation by Dr. Shanmugapriya, final year DCH PG from ICH. We request Dr. Luke Ravi sir and Professor Dr. Kumarasamy sir to chair the next session. Dr. Luke Ravi sir, who has completed his MD Pediatrics from Manipal Hospital, is currently Unit Chief in ICH. Dr. Luke sir is an aggressive go-getter when it comes to patient care. He ensures that no stones are left unturned while helping those in need. Dr. Kumarasamy sir is an alumnus of ICH, is a wonderful clinician, always approachable and brimming with knowledge.
Good morning everyone. I'm Dr. Shanmugapriya, here to present a case of a 5-year-old male child, third born of non-consanguineous marriage, brought by the mother whose reliability is good. He is diagnosed to have heart disease 3 months back. He is on oral medications with complaints of breathlessness, facial puffiness, swelling of legs and abdominal distension for 3 days. History of presenting illness. Child was apparently normal before 3 months, after which he had complaints of fever for 2 weeks, high grade, intermittent and not associated with chills and rigor. He had complaints of joint pain for 2 weeks, initially involving the left ankle joint, which lasted for 3 to 5 days, associated with swelling, which recovered, then pain in the right knee joint associated with swelling, which was a crippling type of pain. He was unable to walk and perform activities of daily living, and the joint pain resolved in 3 days. There is no history of small joint involvement or early morning stiffness. He had complaints of breathlessness for 3 days during the initial joint pain time. He had grade 3 breathlessness. History of increased precordial activity noticed by the mother during that time. For the above complaints, he was admitted at ICH and diagnosed to have a heart disease, and he was started on oral medications. The child improved and discharged after 18 days. He was readmitted after 21 days with complaints of breathlessness, which was of grade 4 according to NYHA, and pedal edema for 5 days. Mother told a history of discontinuation of drugs for the 3 days, probably because of that he had symptoms. So child was on admission for 12 days and symptoms improved and discharged. For the present admission, he was admitted with complaints of breathlessness for 3 days, which was grade 4 according to NYHA. There was history of orthopnea. There was no history of paroxysmal nocturnal dyspnea. He had complaints of puffiness of face, abdominal distension and pedal edema, history of decreased urine output, and history of easy fatigability and abdominal pain. There was no history of syncope, no history of rash or involuntary movements or epistaxis or hemoptysis. There was no history of progressive pallor, painful fingertips, arthralgia or red colored urine. Past history, he was diagnosed of heart disease 3 months back and he was on oral medications. History of sore throat 3 weeks prior to the onset of illness. There was no history of recurrent respiratory tract infections or failure to thrive. Antenatal history is quite uneventful.
See, anything important in the antenatal, birth and neonatal? Anything?
No, sir.
With this history, you have completed the history?
Yes, sir.
So, antenatal, birth and neonatal, everything is normal?
Yes, sir.
Then relevant points alone you guess. Dietary history, nothing is important. Right.
He belongs to socio-economic class 4, sir.
So, socio-economic history, just put that.
He lives in a thatched house with a 4-membered family. There is no separate kitchen. They use unboiled drinking water, and
you think overcrowding is present? How many children?
3 children, sir. The elder one is with the grandmother. So 4 members in the family.
Okay. So with this history alone, can you make some point what you are thinking about?
Sir, it's a 5-year, 4-month-old male child. Belonging to socio-economic class 4. He had fever and migratory joint pain which completely resolved without any residual deformity, and there is a preceding history of sore throat, and now the child presented with features of congestive cardiac failure, so probably it's acquired heart disease of rheumatic origin.
Age is 5 years.
Yes,
so
sir.
This is the first time, 3 months.
Yes, sir.
Before 3 months, child was totally normal.
Yes, sir.
There is no history of any joint pain, anything like that.
No, sir.
Okay. Now with this present history, can you make some diagnosis? So is it acquired heart disease is okay. What could be? So now the child is presented with
fever,
breathlessness, pedal edema,
abdominal distension,
P&D,
orthopnea, and history of abdominal pain and reduced urine output
Okay.
indicating.
So what is your probable diagnosis now? So child was diagnosed 3 months back and child was started on some drugs.
Yes.
What are the, can you say what drugs child was put on? Mother gives any, whether it is
She told child was on diuretics, sir.
Diuretics?
Diuretics, and she's taking regular medications every day, twice daily, probably penicillin.
oral penicillin.
Oral penicillin.
Okay.
And
Child is regularly taking that?
yes, sir.
Right. Mother also, she said, gives a history of sore throat sometime back.
Yes, sir.
3 months back.
3 months back.
Okay. So this child was admitted before this where?
Child was initially seen in a local hospital, sir, and then
Was any investigation done there?
no, sir.
No investigation there. So with this puffiness, pedal edema and all those things, child was referred here.
Yes, sir.
Okay. After admission, what happened in the hospital? You have completed the history now.
Yes, sir. He was initially managed for the initial failure symptoms, and then he was started on oral medications after doing an echo.
So symptoms improved or not?
Symptoms improved. He was discharged after 18 days, sir.
Oh, 18 days.
Then after the mother was taking in regular medications, but she discontinued for 3 days. The child had relapse of symptoms, again breathlessness and pedal edema.
She discontinued all the drugs, including penicillin, anti-failure treatment, everything.
She told the drug was over and she didn't take for 3 days. So as she came to hospital, child presented with failure. Again she was started on drugs and discharged in 12 days. Now in spite of the child is on drugs, he had recurrent symptoms.
See here, when you said overcrowding,
Yes, sir.
which is more important here, overcrowding or the sanitation?
Sanitation,
or the hygiene, or this is-
everything is important, sir. Overcrowding and
Because if you say overcrowding, which is the most overcrowded density in the world?
are
Any wild guess from anyone in the audience? Which is the most density? When you say dense, it means dense people in one particular square kilometer, or too much of people, highly populated area in the world. Which area? It's a very famous area, southeast, Macau.
Mecca.
Okay, Macau, and you won't believe even Hong Kong has got a very highest density. Hong Kong, Tokyo, and why do they don't have this much of rheumatic fever here? Because as I told you, the overcrowding itself simply does not cause a rheumatic fever or streptococcal infection. So for streptococcal infection to occur, it depends on multifactorial factors like sanitation, hygiene, good drinking
Poor
water, and all others are important.
Okay.
And when you say overcrowding, what is the desirable space for an individual human being to live? Average. When you say quality of life, QOL, what we talk normally, no? What is the likely a person requires? Roughly about 200 to 400 square feet for a person. That's why if you just check any jail, hope we don't go there also. The jail is meant for that. If you check anywhere in the jail, there will be space inside the jail with minimum of 200 square feet for a particular jailed individual, because that has to be accessed by human rights. Okay.
Okay.
You said history of sore throat, only one episode.
One episode.
After that, 3 months back she had. Any time back she had again any sore throat or anything that has precipitated?
No, sir.
Okay, right.
General examination. The child is conscious, oriented. He is dyspneic at rest, pale, facial puffiness is present, and there is bilateral pitting pedal edema, and abdominal distension is also seen. Child is not icteric, no clubbing, no cyanosis, and generalized lymphadenopathy. Head to foot examination. Oral cavity, there is no pharyngeal congestion or tonsillar enlargement, no dental caries. There is no erythematous rash, joint swelling, or redness or nodules over the bony prominence.
How do you diagnose streptococcal sore throat clinically? When do you suspect clinically?
Sir, McIsaac score, sir, Centaur score, absence of cough, tonsillar exudates or palatal petechiae, enlarged cervical lymph nodes, and age less than 15 years, 15 to 44 years, and more than 44 years. The score is between -1 to 5. If the score is less than 2, there is no need to treat with antibiotics. If it's 2 to 3, we should do rapid antigen test. and if it is positive, we have to treat. More than 3, 4 and 5, we have to treat with antibiotics.
So clinically, you have to diagnose streptococcal sore throat. Okay.
Yes.
Right.
There is no involuntary movements, no external markers of infective endocarditis. Vitals, heart rate, pulse rate 110 per minute, regular rhythm, large volume pulse, no specific character, no radial or radiofemoral delay. Pulses felt equally in all vessels. Respiratory rate 44 per minute, abdominothoracic type of respiration. BP is 90/60 mm Hg in left upper limb and 100/70 mm of mercury in left lower limb.
So the pulse pressure is only 30.
Yes, sir.
But you said large volume pulse. You are sure?
Yes, sir.
Continue.
JVB is elevated 5 cm above the sternal angle. Anthropometry is normal for age.
Okay, right.
I would like to start with cardiovascular examination. Inspection, trachea appears to be in midline. There was a precardial bulge, hyperdynamic precardium, no dilated veins. Apical impulse seems to be in the left 6th intercostal space, approximately 2 cm lateral to the midclavicular line. There was epigastric pulsations are seen, no scar or sinus. Subcostal and intercostal retractions were there, no other visible pulsations.
When you say hyperdynamic precardium and when you say apex impulse visualized in the left 6th intercostal,
Yes,
is it
sir.
possible? What do we mean by hyperdynamic pulsations?
Sir, regurgitate.
Multiple pulsations. On
Yes,
inspection, I am telling.
Yes, sir.
More than? Should be more than one space.
One space.
Okay. Right.
Two. Tricuspid, the epigastric pulsations seen in the. On palpation, tracheal position confirmed. Apical impulse felt in the left 6th intercostal space, 2 cm lateral to the midclavicular line. It was hyperdynamic type of impulse. There was a systolic thrill present at the mitral area and in the left lowest parasternal area. Palpable P2 is present at the pulmonary area. There was a parasternal heave of grade 3. Epigastric pulsations were felt. Carotids normally felt no thrill. Hepatojugular reflex was also present.
You saw the child when?
Today morning, sir.
Today morning also.
Sir.
Right.
On compressing over the right hypochondrium, there was an elevated JVP.
You are kept at what degree?
45 degrees, sir.
40 degree. Right.
So this is the finding even after 1 week after admission.
Yes, sir.
Yeah.
Percussion, left heart border corresponds to apex and right heart border corresponds to the right sternal margin. Auscultation, I'd like to start with the mitral area. Soft S1, S2 narrowly split, and there was a high pitched soft blowing pansystolic murmur of grade 5/6, best heard with the diaphragm of the stethoscope during expiration in left lateral position radiating to axilla. No S3 and S4 heard. Pulmonary area, first and second heart sound heard. There was loud P2, same murmur of lower intensity heard, no other murmurs. In aortic area, S1, S2 heard normally. Tricuspid area, soft S1 and S2 is normal. High pitched soft blowing pansystolic murmur of grade 4/6, best heard with diaphragm of stethoscope during expiration in supine position. Parabdomen, abdomen was soft, distended. Liver was palpable 4 cm below the right costal margin, which was firm in consistency, smooth surface, rounded borders. Tenderness was present. Liver span is 9 cm, which is high for this child. In respiratory system, there was bilateral antry equal and bilateral basal crepitations were present during initial.
Pansystolic movement. It's radiating only to the axilla or even to the sternal area. Did you see?
Yes, sir. It was radiating to axilla.
You come to the previous slide.
Previous slide.
Yeah.
Left lateral position radiating to the axilla. What happened to the sternum? Is it present? Okay, you complete the diagnosis.
Because you have said it is the murmur is same intensity is heard in the pulmonary area
Yes, sir.
and in the aortic area also.
I didn't
Are
see
you
in the
able to
sternal
Are
areas.
you able to appreciate the path, the murmur, or is it independent of the murmur here?
In tricuspid area. Tricuspid area, it's an independent
That's close
murmur.
by, but what about the aortic area and the sir is asking?
It was same murmur of lower intensity, sir. I didn't check
No,
in
we're
the
not able to
sternal.
appreciate due to the hyperdynamic heart itself.
Yes, sir.
Okay, right.
And summary.
Who else seen the case? Fourth floor, senior PG.
Does all the findings is the same?
You're sure? Fourth floor PG, no?
Obviously, I think. No?
No, actually, I saw the child. So, pansystolic murmur is present, radiating to the axilla. At the same time, the murmur is
Also
also
in the
radiating
sternum.
to the sternum also.
Via the sternum, it reaches the
Okay,
aortic area, comes
right.
to apex also.
Who else? MDPG in your unit?
The thing is, sometimes it might
No one
due
from
to the
fourth floor, eh?
कहाँ थे?
Right. Okay.
sometimes due
right.
to the hyperdynamic circulation, you might not be able to hear the murmur. But when a child is sleeping, ask him to take a deep breath, then you can definitely appreciate the murmur is going all over the chest. It's one of the intensity which is more in the mitral area as compared to the other areas.
Okay, sir.
Right. So now you are summarizing.
Summary.
Right.
5-year-old male child, third born of non-consanguineous marriage, belonging to upper-lower socio-economic status, with a previous history of sore throat and fever and migratory joint pain and features of cardiac failure, with elevated JVP, epigastric pulsations and palpable and loud P2 and parasternal heave, pansystolic murmur in mitral area radiating to axilla and sternum, and pansystolic murmur in tricuspid area with tender hepatomegaly. Probably a case of acquired heart disease, rheumatic in origin with MR and TR.
What is the point for tricuspid regurgitation?
There were elevated JVP and epigastric pulsations.
That you will not get it in congestive cardiac failure. See, you said there is a
pansystolic murmur in the
in the tricuspid area, but you said it is increased with expiration. So what will happen to the tricuspid murmur?
Inspiration.
So the child is very cooperative, but it was not increased with inspiration. So I don't think you have got tricuspid regurgitation. All these features can be explained with mitral regurgitation with congestive cardiac failure. What is the point against?
Murmur was separate murmur, sir. It was not.
See, you said there is no murmur in the sternal area. You said only radiating to the axilla. So only mitral regurgitation alone can explain this feature. What is the point for tricuspid regurgitation?
Sir,
Anybody else?
right ventricular hypertrophy, there was parasternal heave.
What happened? So can all these, so isolated MR, can this produce all these symptoms? You said, what is your diagnosis now? A case of?
Acquired heart disease, probably of rheumatic origin with valves involving mitral and tricuspid.
With pulmonary hypertension.
Pulmonary hypertension, yes,
So
sir.
what are the points for pulmonary hypertension?
There was loud and palpable
P2 is
P2.
Is there any ejection systolic murmur in that area?
No, sir.
It is not that. But parasternal
Parasternal
heave is
heave
there.
was there.
Parasternal heave is there. So features of pulmonary hypertension.
Yes, sir.
So in an isolated MR, can all these develop in a short period of?
No,
so
sir.
usually whenever you get a rheumatic heart disease, what lesion will produce all these features? Will MR will produce or any other lesion?
MR with MR.
What is the hemodynamic in an MR?
Sir,
What will happen in MR, acute MR? You tell me the hemodynamics.
there will be annular dilatation, sir. So there will be elongation of cord tendinae and cord
So
edema.
what about the flow of blood? The
So
flow of
whenever
blood
there is an acute
During diastole,
MR,
there will be,
the leak of blood will be, what will happen?
left ventricle to
left ventricle
left
to left
atrium.
atrium.
So left
Yeah.
atrium will
The
be
left ventricle will have two exits.
Yes, sir.
One into the aorta, one into the
into
left
the left
atrium.
atrium.
Mitral.
Okay, in an acute MR, what will happen? So the left atrium will get dilated. So what will happen?
Sir,
There are
will
two,
pulmonary
volume overload and pressure overload.
Volume
There are two
overload.
things you have to keep it in mind.
Yes, sir.
Even it is a volume overload, whenever the mitral regurgitation is there, the left atrium, if it is a chronic case, it can accommodate more blood and the pressure will not rise there in left atrium. This will not reflect into the pulmonary veins and pulmonary congestion will not occur and they will not develop pulmonary hypertension so easily. So whenever you have got evidence of pulmonary hypertension, there should be either mitral stenosis associated or
separate.
it is an acute MR. Acute. For example, where you get an acute mitral regurgitation.
Acute rheumatic fever.
See, it's very simple. The history is very short.
Mitral valve
As the sir
prolapse.
tells, it's very short history with a mitral valve occurring and with pulmonary hypertension. This cannot be a isolated mitral incompetence alone.
Okay.
Because what happens in the hemodynamics during systole, when the left ventricle, it comes to blood, goes back in systole, it goes back
Left
to left
atrium.
atrium also. There is a leak from the left ventricle to the left atrium, and also due to the increased vascular resistance, again some blood goes into the aorta also.
Aorta.
So what happens here exactly? As sir told, there is the
Left atrium will be
pulmonary
overloaded.
vasculature does not get the burden
Okay.
because the blood is equally distributed. It's only the volume enlarges, so it is only a left atrial enlargement.
Okay.
Okay, so it accommodates the blood inside. So for pulmonary hypertension to occur, there need to be another valvular lesion
Lesion.
because it's short duration. Short duration, as you told, a neuro auto surgeon, it is on the grade 3 dyspnea. Now it is grade 4, and as we tell, even for the past 1 week, child is here, looks comfortable, but still the symptoms are not
Symptoms are-
decreased. So these are the points which favor additional valvular disorder when there is a, well, that's why he is asking, what are the points here to say it is not an isolated MR? So pulmonary hypertension is the main one here.
Okay.
Now my second thing is, what is predominant here? Is the cardiac failure predominant or is the carditis reactivation? Can you say by history and physical findings?
Sir, he's having an established heart disease, sir. Probably reactivation.
No, you have to think very clearly. See, you said it is a 3 months. You said
Failure.
perfectly child is normal, well averagely nourished child. 3 months before there was no lesion, playing around, running up and down. Suddenly 3 months back, mother noticed to her. What was the first history mother noticed? Had a pain and
in the
swelling in the left knee joint.
Yes.
Subsequently came to the right knee joint, then developed fever, then developed dyspnea. So classical. It's a
case.
classical rheumatic history only. So now within the 3 months it has progressed much, and they have put multiple drugs have been given. And
Yes, sir.
though the baby has skipped taking the drugs for 3 days, but the problem is so phenomenal, it has reached to such stage. So here I just want you to tell whether the carditis is predominant here, making all this, or it is a congestive cardiac failure part which is predominant here. From history, for this child alone.
Failure part is predominant.
So
sir.
failure is predominant here. That's what
Yes, sir.
mostly failure is predominant, because again, what is the reason for the failure to become predominant here?
So you said mitral regurgitation is there.
Yes, sir.
So when, see, suppose all these symptoms are, see, simple, there is a mitral stenosis there, mitral regurgitation is there, which will develop pulmonary hypertension very fast.
Regurgitation. Mitral stenosis, sir.
That is what?
Stenosis will
Only
develop.
mitral. See, in a regurgitation, the left atrium can accommodate
Yes,
more
sir.
blood. So that
Stenosis,
will not reflect there.
It will not
So
create any
only
burden.
the pressure overload will reflect on the pulmonary
Pulmonary
vasculature and
hypertension,
produce. Okay, but even in case of simple mitral regurgitation, if there is an acute phase like rupture of
Cardiac
Cardiac
amyloid.
chorda tendinae, so when there is an acute insult, in that case, all these symptoms can occur.
Yes, sir.
Do you understand?
Yes, sir.
So that should be because you said child was normal. Every history is only for the past 3 months. So
Okay.
probably this time when the child would have admitted, you would have had some rupture of chorda tendinae. When there is an acute MR, the left atrium cannot accommodate, cannot have time for it to dilate and accommodate the regurgitant blood. So the pressure reflects on the pulmonary vasculature and develops pulmonary
Pulmonary
hypertension.
hypertension.
You have
Okay.
understood now.
Yes, sir. Yes,
But otherwise, what any other, is there any evidence for mitral stenosis?
No, sir.
Here, history for there is there is no
Any
findings.
Sir,
clinical wise? Any evidence
Sir,
for
it
mitral
usually
stenosis?
develops after 5 to 10 years of initial insult, sir.
No,
Ah,
இதுல.
in tropical countries like us, even 3 years is enough. Western countries they give more than 5 years, but here 3 years of any streptococcal infection following that any rheumatic etiology can cause mitral stenosis, but not less than 3 years. Okay, so the all your findings are correct, but only these things you have to explain like this.
Okay, sir.
But I don't think this TR is significant or organic here. Probably pulmonary hypertension
The rupture.
causing right ventricular dilatation and then causing all these symptoms of even that congestive cardiac failure can cause all these symptoms. Okay, right.
Because actually we know very well rheumatic can cause myocarditis, can cause pericarditis.
Endocarditis and
So part of
pericarditis.
CCF can occur initially and then as he told can go for a mitral causing rupture of the aorta tendina. Then only there is a problem of going into pulmonary hypertension. What are the various parts of the mitral valve? Which part is very risky?
Commissural,
Yeah, we
cuspal,
have
caudal,
annulus, leaflets,
leaflets,
commissus, papillary muscle and
chorda
chorda tendina.
tendina.
Okay, among these, which are the most sensitive and which is more important here?
Commissural chorda,
For a cardiothoracic surgeon, which is important here?
papillary.
Okay, it's okay. Carry on. Carry on.
So you understood now?
Yes.
So it should be an acute MR, probably because of some rupture acute, and then it would have produced. Can this be because of infective endocarditis?
No, sir, no.
So there is no prolonged
clinical
fever.
Arthritis.
Even sometimes the problem is whenever you get some infective endocarditis, that can even rupture the valve and produce acute MR. In that case also you will develop features of acute MR, pulmonary hypertension, all these features. Okay, right.
With features of congestive cardiac failure, pulmonary hypertension, no evidence of infective endocarditis with normal nutritional status.
Right. What are next investigations you have got?
Investigation initially
You have not put. Oh,
How do you want to establish this? See, the child comes to you. We are sitting there in the OP or casualty, whatever it is. This child comes to you, present history. What is the first and foremost thing you will do?
sir, initially
So
we
you
will
need to
check.
you need to differentiate between a sick child and normal child. You need to go for specific case specific investigations. You must do. So what are the bedside things you can do immediately before you can order for other things?
Sir, CB. Bedside.
What is a dictum in rheumatic heart disease? Rest, bed rest.
Bed rest.
So once you establish rheumatic, you take a bed rest. Then what do you do?
Sir, if the child is having features of failure, we will have to give bed rest, diuretics.
Yeah.
And initially, we have to settle the failure with
First you
oxygen.
stabilize the child, giving adequate oxygenation. And then,
Oxygenation.
because what happens when the child gets more fatigue? What is the cause of fatiguability in these children? Hemodynamically.
So they are not able to meet their demand because
Yeah, because what
Because of
happens?
the reduced-
There is from the leak, there is a blood going from the left ventricle to the left atrium, so less amount of blood goes through aorta. So the body is not able to meet the demand with the reduced blood, and so there is a easy fatiguability. Okay, how does it get compensated?
Sir,
How does that get compensated? Why there is palpitation? Due to the resting heart rate.
resting heart.
Okay, the heart rate takes over the charge and starts increasing heart rate. Okay.
Because of the tachycardia.
Okay.
Then
go for investigations. You explain, you tell the investigation why you are doing, what do you expect.
initially CBC, if we hemoglobin, if it is less,
அதை முடிச்சிட்டேன்.
we should look for anemia, sir.
Anemia. Why?
Sir, anemia can precipitate further heart failure.
Can
sir.
aggravate again
Heart
congestive cardiac failure. Right. What was the hemoglobin in this child?
9.8, sir. There was
8.
one Paxil transfusion given.
Oh, right.
And total count, whether it is elevated, ongoing infection, then ESR CRP has to be done, sir. If CRP and ESR are elevated, that is one of the minor criteria for the rheumatic fevers. And then to prove antecedent streptococcal infection, ASO titers, anti-DNAs if possible, and rapid antigen detection test, throat culture if the child is having acute symptoms of.
How long the ASO will be positive?
It 6 to 8 weeks until 6 months child will
Can
have
expect
positive.
till 6 months because all these histories were only dating
Before
to 3
3
months
months.
duration.
Yes.
Right.
And X-ray, we have to look for cardiomegaly and evidence of pulmonary venous hypertension, and ECG, look for any left ventricular hypertrophy.
More and more left atrial enlargement you will see.
Left
How do you
atrium.
see that?
Left when
Your tall
P
T is-
mitral,
yeah, tall
my P
T,
mitral.
V4, V5 and then
Then for left ventricular hypertrophy, we'll have to count the S wave in V1 and R wave in V6, and if it is more than 30 we will tell it is left ventricular hypertrophy. And echo to look for any vegetations.
Yeah, first
And
you see
initially
the valve. First you see the
cardiac
valve.
dilatation and
Yeah.
valves regurgitations. Then caudate tendinae, any caudal edema or annulus dilatation and elongation of the caudate tendinae will be there. Lack of coaptation of the leaflets will be there in echo.
What else can you see in echo?
Vegetations.
Yeah. Then some more. You have to see also here.
Left atrial appendage.
Yeah, left atrial clot
appendage.
you must see. Left
Yes.
atrial clot. Okay, all that you should not miss. When you do
Okay.
an echo, we should have all the. Should see for look for everything in there inside. Okay.
Okay.
Right.
Then from
What is the management for this child? So you have done investigation. So with this investigation, with what conclusion you have come?
it's a rheumatic heart disease and the child needs prophylaxis lifelong, sir.
Now presenting with congestive
cardiac
cardiac
failure,
failure.
and pulmonary hypertension.
Right. Okay. Now, what is the management?
Bed rest, sir.
Yeah, bed rest, oxygen. Then how do you step by step you elaborate? Yeah. Like a
bed
flow
rest-
chart you can tell. Yeah.
Bed rest
What
we'll have to
exactly do in the ward you tell?
bed rest we'll have to give oxygen, 40 to 50% oxygen with humidity, and we'll have to give diuretics initially to settle the pulmonary edema, and enalapril can be given for cardiac remodeling, and we'll have to start the child on steroids since there is severe carditis, and
No, you said child is in carditis
Cardiac
or
failure.
established cardiac lesion now.
Yeah.
established heart disease, sir.
And then
See, that's it.
Confuse
See,
it.
unless we have a clear mind on that, the management changes.
Yes,
A
sir.
cardiac failure, a carditis.
Cardiac
Okay,
failure, sir.
so
how
just-
do you
yeah.
differentiate between, suppose if it is presenting with severe, congestive cardiac failure, it should be severe carditis with
carditis.
congestive cardiac failure. What are the points you want to say if the child is in severe carditis clinically?
Child is having features of failure, sir, and child is having
See, even an established heart disease can go in for congestive cardiac failure. Anybody else? You are going to auscultate the child daily.
yes, sir. New
Whenever
change
you
of
say
murmur
change in the intensity of murmur or
Or a
an
new
appearance
murmur,
of new murmur,
evanescence.
that shows child is going for still active carditis is
Carditis.
present. Suppose the child is presenting with severe carditis, what will be the management?
We'll have to start him on steroids, sir. 2
Dose?
mg per kg per day in 2 divided doses. We'll have to give for 2 weeks, then give 1 mg per kg per day for 2 weeks, and during 5 mg we have to taper 5 mg every 3 days and stop. During tapering, we'll have to start aspirin 50 mg per kg per dose in 4 divided
50 to
doses.
70 milligram per
per
kg.
kg.
For how long?
Total duration is 12 weeks, sir.
12 weeks.
And how do you check how long we give aspiration? Is there anything you do? sir?
ESR.
Yes, sir, exactly, correct. Okay.
So what is the role of ESR in a child with rheumatic fever?
It will rise immediately, and it will be present for prolonged time, so 6 to 8 weeks.
Again, rheumatic fever,
with
what is
the-
the importance
with
of
the-
ESR? What is the
Importance.
importance or what is
Sir, in
significance of ESR?
high risk,
Well,
if
simple
ESR
rheumatic-
normalizes with our treatment, child is responding, and carditis is not
Initially
active.
in acute rheumatic fever, ESR will be elevated. It's taken as one minor
Minor
criteria.
criteria.
It is a-
Then based on this, suppose you have got severe carditis like that, you will have to check the
The
ESR.
ESR.
Only when the ESR becomes normal, you will have to switch over to aspirin.
Aspirin.
Okay. So usually it will be settled down by
2
to
weeks.
3 weeks. Then you step down to aspirin, and then taper the dose of steroids.
Steroids.
Okay.
See, it is an
Right.
acute phase reactant. So there is an inflammation initially, ESR rises. So when it comes down after steroids, the information response is decided by the ESR. As it comes down, we taper and then we start an aspirin. So starting up aspirin is based on the reduction of the inflammation. Okay. What other drugs we give apart from this? So now
for
we
failure,
consider this child is a failure. This child is a rheumatic heart disease, mitral incompetence in congestive cardiac failure. So you have told very clearly bed rest, oxygen, then we give
we'll have to,
after load reducer. Then what else do you want to give?
AC inhibitors.
Very good. What is the role of AC inhibitor here?
So it will block the angiotensin conversion of angiotensin 2 by blocking the AC angiotensin converting enzyme. So this will reduce both preload and afterload, sir. Okay. So cardiac remodeling will be supported.
It also reduces the systemic resistance. So enough blood comes to the peripheries. So thereby again we need to save the child from going into pulmonary hypertension. But here child is already in pulmonary hypertension. The role is to reduce the child to go into pulmonary hypertension. Okay. Then what other drugs do you give apart from this?
So digoxin if the child is not having any myocarditis.
So this child, does it require digoxin or not?
No, sir.
How do you say?
So child is in failure, sir.
Again, we come back to the original question. Carditis failure. Okay, I think anybody? This child, does this require digoxin or not? Yes or no? If yes, why? If no, why? See, here we have got multiple people. Lot of people are there here. My friend Kumarsamy is there. He will help you out. When you go to a primary health center, Talgate quarters, you are alone. You can't Google. There will be 10 people watching you what you are doing. Okay, so you need to take some decisions quickly.
Myocardium is sensitive to digoxin.
No, very clear. This child with the history findings, do you want to add digoxin or not? How many? Can someone tell? How many favor digoxin here? Raise your hands. One person raised and suddenly put his hand down also. Seeing others are not raising their hands.
See, if the child is in severe congestive cardiac failure, you can use digoxin.
There's nothing wrong in giving digoxin.
Only if there is evidence of myocarditis, even in myocarditis with congestive cardiac failure, you can use half desalinization. Okay, there is no contraindication, but you have to monitor the potassium level. Okay, now this child has presented with this. You think it's an established heart disease now, or it's still an acute rheumatic fever?
Established heart disease.
Okay, now established heart disease. Now what is the line of management for this child?
For this child, now what next you can do? This child 3 months history, a short history, we have given all the anti-inflammatory, we have given aspirin.
Child is having...
And 1 week child is still the same even after starting all treatment. So what is the next likely treatment as a consultant you can offer the child?
Surgical management.
So what type of surgery? Here comes my back question. What is important here? Which part of mitral is important?
Why surgery is now?
Why the child is...
Annulus is very important. Okay. Okay. If there is surgery, what kind of surgery can you prefer? This child is aged only 5 years.
So, mitral valvuloplasty.
Annuloplasty. Why can't you do a valve replacement? They are very rich.
So they need to take anticoagulants lifelong. And
they will take what else?
Then risk of hemolyte.
Availability of the size of the prosthetic valves, and we know very well they are bound to have
infections.
Infected endocarditis. More than 3 years they will not say. Again you have to reopen. So redo MVR from the age of 5 years. How many times you can redo? So they try to minimize the intervention. But when there is no other go, child has gone into pulmonary hypertension, has to survive, they go for an annuloplasty. Okay. Valve replacement generally they wait up to the teenage. Beyond the teenage only they try to offer it. Okay.
So because the child is presenting with only mitral, so all these features can be explained only with acute mitral MR, going in for congestive cardiac failure, and then it can develop pulmonary hypertension, all these features. So because it's an acute, it should be some chorda tendinae rupture or something like that. So you do a detailed echo and you'll have to go for mitral valve repair. Okay. So further mitral valve repair, you are sending the child for valve repair. Now further what is the course of event and what else you will advise for the mother?
We'll have to oral hygiene is very important, sir. And infective endocarditis prophylaxis and rheumatic fever prophylaxis has to be continued lifelong. And anticoagulants to prevent arrhythmias.
No, when you have done a repair alone,
MVR, might replacement.
When you are replacing,
Yeah, that is
you will have to.
different. Yeah.
When you are doing
Angioplasty,
repair, see,
repair alone.
repair is very easy when compared to replacement. Replacement is always, it's a very difficult surgery. It's only a MR. So it's better you replace it. I mean, you repair it. So once you repair it, they may not need long-term anticoagulants. Okay, right. Then you'll have to continue lifelong
Lifelong prophylaxis.
Penicillin
prophylaxis.
So when you give anticoagulants, you have to maintain the INR between 1.5 and 2.
1.5.
But it's not indicated as sir told for annuloplasty, it's not required. Only when you do a replacement, MVR, repair, reconstruction, then only you go for it. Okay.
Okay.
So can this child again develop rheumatic fever?
Yeah. The next question. The
Yes,
parents will
sir.
ask you.
Yes, sir.
That is why you are continuing
Lifelong
your
prophylaxis.
Okay, what is the weight of the child?
16 kgs, sir.
16. So what drug you are giving and how much you are going to give?
Penicillin, he's on oral penicillin, sir. 250 mg twice a day. And if you are giving penicillin, it should be given every 21 days at
Which is
6
better?
lakh. Injectable form
Injection
is
is
better.
better.
What is our
Better
reason?
for the child, which is better for the doctor. Giving penicillin is very, very difficult. So it's don't make an attempt.
What is the
Better-
recent scenario? NHM, what does NHM tell now for penicillin? What does NHM tell for penicillin and
Injectable penicillin every 21 days.
yeah,
Sir.
so it's very difficult in peripheries. You have to admit the child, you have to give penicillin, and what happens? Sometimes they may not come back also. They may not come back to the
Uh,
hospital
For,
facility, they may not come. Okay,
Okay.
so is there any scheme or anything as government has done for rheumatic recently, or is there any scheme or anything now, NHM?
in school going
It's
children.
only RBSK what we are doing. There is no scheme as such for rheumatic heart disease prevention. Why? Because now the government's main priority is for non-communicable diseases like diabetes, hypertension, myocardial coronary. So this has actually come down. Only in ICMR they had a passive, they did a survey between 2000 and 2010 ICMR, they found out not much of children they had. Only maybe somewhat something around 3 to 5 per 1000 children had the chance of developing a rheumatic fever. But after 2010, the government, I thought probably they thought they have controlled the rheumatic fever, but still we have not controlled the rheumatic fever, because as you know very well, controlling rheumatic fever is multifactorial. It is not the overcrowding, it is a hygiene, sanitation, good drinking water, boiled water. Because when you say, as I told you earlier, New York, Tokyo, Hong Kong, they are more overcrowded than us. Then why are they not getting rheumatic fever? Because of good living conditions, good sanitation, good drinking water. So the factors are not only overcrowding, it is also due to
Poor
personal
sanitation
hygiene.
and
That's also
hygiene.
very important. Okay.
Okay.
So in summarizing, this child probably had some insult 3 months back, discontinued the drugs,
Treatment.
and then child again landed with features of rheumatic fever with congestive cardiac failure, probably because of mitral valve
Regurgitation.
regurgitation. That would have developed all these features of pulmonary
Pulmonary hypertension
hypertension.
and tricuspid.
So needs immediate surgical correction. Otherwise, because already child has developed pulmonary hypertension, P2 is loud, parasternal heave is there. So all these features goes towards developing pulmonary hypertension. If you don't do surgery, so child will irreversible pulmonary hypertension. So the child, nothing can be done. So earlier surgery will be the better option for this child. Okay, right.
Okay.
I am not convinced with TR because it is not, child is very cooperative. So even with when you ask you to inspire, this child is doing it, the murmur is not increased. So probably all this may be because of RVH,
Rupture.
right ventricular
Hypertrophy.
dilatation and causing TR.
Okay. sir.
Okay, right.
So the take home message is very simple. Early identification of a throat infection, because we know very well throat infection can go for a rheumatic fever. So early identification of a throat infection, because this child has gone several times to the village nearby, they have given multiple injections, but nobody has given any penicillin antibiotics, if you probe the history. Because why we have not brought the child here, because we too decided not to bring the child here, because child is still not alright. It is sick looking with a carditis. We did not want the child to be shifted here. If anything happens here, then all of us will be in the soup. So early recognition, because as the history goes very clearly, 90 days a normal child goes from a normal to the valvular lesion with a pulmonary hypertension. So probably rupture of carotid angina alone has got a major part, because not all children will have a trouble. Only few children they go for a cardiac failure and this sort of symptoms. So this is definitely a acute MR and definitely needs a corrective, either a surgery or an annuloplasty. As sir told, this is the matter of mind. Okay. So early identification, early intervention is very important. Thank you.
Thank
A
you.
very good, wonderful presentation by Shanmuga Priya, and again because PGs have come all over in India, I think, and like to congratulate her and other PGs. When there was a dengue epidemic and when the fever epidemic, we have seen all these people, postgraduates sitting here and working non-stop, 12 hours. And when me and Srinivasan sir were able to catch little hour of sleep in the night, it was all because of these people. Excellent postgraduates we have and excellent patient care they are giving. So once again, we wish all the best to all of you. Success.
Thank you.
Thank you.